Good morning, Ashwath. You can start the presentation.
Good morning, sir. Starting, sir. Topic for today is scapular fractures. Scapular fractures account for less than 1% of all fractures in the body. So it is a rare entity. Today we'll discuss about it. Uh, Starting with the anatomy of the scapula, we can see the scapula is a part of the appendicular skeleton and it is attached to the clavicle and humerus by means of ligaments. It is attached to the sternum by the clavicle is attached by sternoclavicular joint and the scapula is attached to the clavicle by the acromioclavicular joint, and there are also coracoclavicular ligaments. It has two parts, a conoid ligament and a trapezoid ligament. Then it is attached to the humerus by the glenohumeral joint. It is a capsule. So this is a osteology of the scapula. Figure A is the anterior view and figure B is the posterior view. Parts of the scapula are the blade or the body, which articulates with the thorax. And then there's a spine of the scapula posteriorly. The spine divides the scapula into a supraspinous fossa and a infraspinous fossa above and below, which contains the muscle supraspinatus above and infraspinatus below. Then there is an acromion. Acromion is nothing but an extension or a continuation of the spine of scapula. Acros, the Greek word, means the highest point. So this acromion gives origin to the deltoid muscle. And in the anterior view, we can see there is a coracoid process. Coracoid process is, it comes from the Greek word raven's beak. It has a beak-shaped morphology and it gives rise to biceps, short head of biceps muscle and coracobrachialis muscle. Then there is a laterally a glenoid, which is a socket, which extends peripherally circumferentially by means of a labrum. Important point, notice this glenoid is placed in a 30-degree anteversion. So this is a brief osteology of the scapula, and there is something called triple SSSC, triple SC. It is the superior shoulder suspensory complex. It is a osteoligamentous ring. It comprises of glenoid, coracoid, acromion, and distal clavicle with their ligamental stabilizers with AC joint and coracoclavicular ligaments. It is supported on the struts of clavicle and scapular blade. It maintains the normal stable relationship between upper limb and the thorax. This is best appreciated by in the scapular Y-view X-ray. So coming to fractures, when the patient presents to the emergency room, the first thing we are doing is getting a history. Most common chief complaint is pain and inability to move the affected shoulder. So we have to ask for a history of injury, whether it is traumatic or atraumatic, or if it is a recurrent complaint. Recurrent complaint can be due to instability. Most commonly, fractures present with acute definable injury. Injuries can be motor vehicle collision or a fall from height. These two injuries are high velocity injuries. So we have to rule out any associated injuries such as hip fractures, clavicular fractures, hemopneumothorax, etc. The other comparatively low velocity injuries are fall on outside stand and blunt impact or a blow to a shoulder. The rare history is epileptic seizure or electrocution, which should raise the suspicion of posterior dislocation of shoulder. In coming to examination, we are going to look, feel, and move. We are going to look in inspection. We have to see for the symmetry of the shoulder and the loss of deltoid contour in a patient of shoulder injury. Any loss can be suggestive of a shoulder dislocation. Then we can see for bruising on the affected side, on the back as well as on the front, and we have to see for any external injuries such as abrasions. Then feel on palpation, we are going to feel the following bony prominence or the landmarks, and in each point we are going to see for any bony tenderness, any crepitus on palpation, and any abnormal mobility or loss of contour. The points to be palpated are sternoclavicle, starting from medial to lateral, sternoclavicular joint, the shaft of clavicle medial to lateral, then the acromioclavicular joint, acromion process, the scapular spine, humeral head, humeral shaft, and biceps tendon. Then we are going to assess for the range of movements. Ask the patient to do shoulder range of movements, flexion, extension, abduction, adduction, external, internal rotation. We are going to check both active and passive range of movements. So these are a few quick tests to screen the shoulder. Abduction with external rotation and adduction with internal rotation. And then we have to check for individual muscles, especially the rotator cuff muscles, which is likely to be injured in the case of scapular injury. Checking for the supraspinatus muscle. We have to do a Job's test. We have to ask the patient to abduct the both the upper limbs to 90 degree and move it 30 degree forward to match the anteversion, and then bring the thumbs down, which is the empty can position. That is by internal rotation, and then the examiner tries to push down the elbow and ask the patient to resist the examiner's force. We have to check for any anterior superior shoulder pain. This is Job's test. The next test is supraspinatus was mainly the function is abduction. The next group of muscles to be tested is infraspinatus plus teres minor. Their function is external rotation. Ask the patient to tuck the elbow to the sides and forearms to be parallel to the ground, and then resist the patient attempt to ask the patient to external rotate, and we have to resist their attempt by pushing their hand and wrist together. Check the power and compare the power on both sides. This is resisted external rotation done to test for infraspinatus and teres minor. The third muscle to be tested is subscapularis. Its function is internal rotation. There are two tests to check for subscapularis. One is Gerber's lift-off test and second is belly press test. Gerber's lift-off test asks the patient to put the dorsum of the hand on the back or the buttock region and ask the patient to lift 10 centimeter posteriorly, and we can ask them to hold in that position. And further testing is to resist the force of the examiner. The other one is belly press test. Put the hands on the belly and press the belly inside, and well, the patient brings their elbow forward and the examiner tries to push the elbow posteriorly. One important entity associated with scapular fractures is it is a high velocity injury most of the time, so we have to see for associated injuries. Associated injuries can be nerve injury, which is brachial plexus. We have to test for the brachial plexus by testing the individual nerves and as well as the myotomes and dermatomes. Then there is a possibility of vascular injury. So we have to check the distal pulse and capillary refill time. Then the patient can have a floating shoulder or associated other fractures. So you have to check for a clavicle and a humerus also. Then most often it is associated with rib fractures. The patient might have hemopneumothorax with breathing difficulty and a flail chest. So we have to rule out rib fracture and intervene for hemopneumothorax with ICD tube if necessary. And joint, they can be associated with glenohumeral dislocation, so the joint also has to be examined. And then the muscle rotator cuff test, as we discussed earlier, it has to be examined, these four muscles. After examination we are going to do a imaging. We proceed with an x-ray. The first x-ray to be done is a x-ray shoulder anteroposterior view. We always prefer to do two views. The first view is a anteroposterior view. In this anteroposterior view, the beam is in the sagittal plane and the patient is head on facing the beam, and uh, with the structures visualized are the clavicle, acromioclavicular joint, acromion, and the proximal humerus. One thing is this projection is oblique to the glenoid, so we can find some amount of overlap between the glenoid and the humeral head. So, in order to get a proper view of the joint congruity, we are doing a true AP view. In this, we are tilting the body torso of the patient 30 degree, and the beam is projected in the plane parallel to the glenoid to assess for the congruity of the glenoid. Here we can see the joint space and the joint congruity can be well appreciated. This is a true AP view. Other than this, we are going to do some special views. Special views as axillary view. In axillary view, it is a top-down view through the shoulder. The humeral head and glenoid are seen well, but there is a prerequisite to do this view. We need the patient to abduct the arm to 45 degree, which might not be possible in most of the cases of acute injury. So, In the place of axillary view, we can use a modified axial view. In modified axial view, the patient has his upper limb on a arm sling, and then he leans back 30 degree over the cassette, and the beam is directed from above. In this also, we can see the humeral head and the glenoid. This is modified axial view. And the last one is uh, scapular Y view. Scapular Y view is used to see the superior shoulder suspensory complex and the glenoid, end-on view of the glenoid, and it gives a direct lateral view of the shoulder as the scapular blade can be seen. So in this also we are rotating the body 30 degree to match the scapular anteversion. We also want to see the clavicle. Usually the clavicle is seen on a AP view, but it tends to overlap with the ribs and the upper part of the scapula. So the best view to see the clavicle is a 20-degree Kefauver tilt view. We take a exercise with 20-degree Kefauver tilt to visualize the clavicle. And if the fracture anatomy cannot be properly appreciated, we proceed with a CT with 3D reconstruction. And once you visualize the fracture, we have to classify the fracture. The classification used for scapular fracture is Heidelberg and Gauss classification. It consists of 6 types. First type is a avulsion fracture of anterior glenoid margin. And second type is the fracture exits inferiorly. In second, there are two subtypes, type 2A and 2B. 2A is a transverse fracture exiting through the glenoid fossa inferiorly. 2B is a oblique fracture. It is also exiting inferiorly. Then type 3, it is oblique fracture exiting superiorly. This type is often associated with the acromioclavicular joint injury. Type 4 is transverse fracture exiting through medial border of scapula. Type 5 is a combination of type 2 plus type 4. And type 6 is severely comminuted of fracture of glenoid surface. Complications. As we discussed earlier, most of the complications are the associated injuries. Local complications can be neurovascular injury. They happen 90% of the time. And late complications, local can be flail limb in 50%, and amputation, it can be performed in 20% of the patient. And 10% patient end up dying because of polytrauma and other associated injuries. Treatment. Most of the scapular fractures can be treated conservatively using a simple cuff and collar or a broad arm sling. We can use shoulder mobilizer, and if it is associated with the rib fractures, we have to encourage the patient to do deep breathing exercises and incentive spirometry. Along with it, we have to give ice pack and analgesics. Rarely surgery is indicated in case of a scapular fracture. Uh, some of the indications for surgery are scapular neck fractures with severe displacement of glenoid, and type 1 fracture with more than 20, this anterior glenoid rim avulsion. If more than 25% is involved, it might result in instability. So we have to consider surgery. And type 2 fracture with humeral head subluxation, and type 3 to 6 with incongruity of the glenoid. Floating shoulder injuries must be considered for fixation, and two or more components of SSSC injured. Most common combination which we encounter is scapular neck fracture plus clavicle shaft fracture. And isolated acromial fractures might cause impingement. So, open accidental fixation with plating is done. These are some of the implants which are available for scapula fixation. And these are the post-op radiographs. We have a medial plate and a lateral plate and acromion specific anatomic plate. So the surgical approach used to fix the scapula, there are two approaches. One is a Judet approach and other is a Brodsky approach. Judet is the posterior approach to the scapular body. Exposure of the body and articular segment of scapula is based on extensile Judet approach. This approach permits exposure of medial border and the body along with the lateral column and the articular segment. Everything can be addressed using this one approach. It There is a modified Judet approach which avoids detachment of deltoid muscle, which gives almost the same exposure. So structures to be taken care of during this posterior Judet approach is we must not injure the suprascapular nerve. at the spinoglenoid notch on its way to supply the infraspinatus muscle. And teres minor is supplied by a posterior branch of axillary nerve after giving a pseudoganglion. It emerges from the quadrilateral space along with the posterior circumflex humeral artery and the vein. So position, we usually operate this in a lateral decubitus position, which is the preferred position. It can also be done in a prone position. The injured limb is supported on the arm support with arm between 45 to 90-degree abduction relative to the scapula. And we have to mark the anatomic landmarks before making an incision. The important anatomic landmarks are posterior corner of the acromion, posterior aspect of the acromioclavicular joint, medial end of scapular spine, and inferior pole of scapula, which is shown in the picture. Skin incision. For Judeth's approach, we begin at the posterior corner of the acromion, continue along the spine of scapula to its medial border, and then distally to inferior pole of scapula. Then we have to dissect layer by layer. The skin is elevated at the epiphyseal level to expose the inferior border of the deltoid muscle. Uh, we have to take note that extensive desquamation to be avoided to reduce risk of skin necrosis. So after detaching the deltoid from the spine of the scapula for access to superior part of the articular segment, then we have to elevate the infraspinatus muscle from the infraspinatus fossa and retract it laterally to expose the entire posterior aspect of scapula. We can visualize the posterior aspect of neck of scapula, posterior glenoid rim, and posterior scapular body. This is how it looks after the exposure. Here we can see the suprascapular nerve and artery coming from the supraglenoid notch. The infraspinatus muscle is reflected and the deltoid is retracted superiorly. The other approach is the Brodsky's approach. This approach can be chosen if we are planning to apply only a lateral column plate. So if exposure of lateral column and articular segment without exposure of medial border is indicated, we can go for a Brodsky approach. Both exposures are based on internervous plane concept. So the internervous plane is the plane between infraspinatus and teres minor, because infraspinatus is supplied by suprascapular nerve and teres minor is supplied by axillary nerve. Sometimes we might need a minimal access over the medial end of the scapular spine alone. So Brodsky approach can be combined with a limited incision in the medial end of scapular spine. In Brodsky approach, the red line marks the incision. It begins from the the inferior pole of the scapula and parallelly along the lateral border of the scapula. It is to be noted that the proximal part of the incision always lies just medial to the posterior corner of the acromion. After incising the skin and taking down the subcutaneous tissue, the deltoid muscle is retracted superiorly again after incising the fascia or inferior border of the muscle, taking care to avoid traction on the axillary nerve and posterior circumflex humeral artery. This retraction exposes the infraspinatus fascia. We have to incise the fascia of the infraspinatus muscle on line of the muscle fibers. This interval is identified to expose the internervous plane between the infraspinatus and teres minor and exposing the long head of triceps laterally. The long head of triceps arises from infraglenoid tubercle. The long head of biceps arises from supraglenoid tubercle. So following this muscle upwards to its attachment, we will reach the infraglenoid tubercle. And if at all we want to expose the joint and the articular segment, exposure of superior part of the articular segment and glenoid rim can be performed and through the interval between supraspinatus and infraspinatus. Care should be taken not to injure the nerves to infraspinatus. The interval between teres minor and teres major is identified uh, by exposure of circumflex scapular vessels. This interval permits exposure of remainder of the lateral column. Seen in the first figure, the circumflex scapular artery and the interval. Uh, the last figure shows a transverse posterior glenohumeral arthrotomy being done, which exposes the glenoid fossa. If at all we want to check if any screw has penetrated the joint surface, we need to expose the joint articular surface. For this, we need to do a transverse posterior glenohumeral arthrotomy. And once we have fixed the fracture, we can proceed with the wound closure. the wound is irrigated and joint capsule is repaired. We must repair the infraspinatus muscle fascia. The deltoid fascia need not be repaired, it is not necessary. And then close the subcutaneous tissue and the skin. So the take-home message of this presentation is scapula fractures are suggestive of high-energy trauma, having a high index of suspicion for other shoulder girdle fractures, associated injuries to thorax, including ribs, lungs, great vessels, and the brachial plexus. These are more important injuries and can be life-threatening also. So these injuries have to be given priority and screened first in the emergency room, and all the injuries are to be documented, and the patient has to be treated as a whole. Thank you, sir.
Thank you, Ashwat. The concept of dealing with scapular fractures is it's a very nice bone surrounded by good vasculature and heavy muscles. And as such, isolated scapular fractures do not need any fixation because they have a good tendency to heal. And even if they malunite, it's not going to cause any trouble except for slight dyskinesis, which can also be managed with proper scapular rehabilitation. The only conditions where scapular fracture needs to be dealt with is in case of the acromial fractures, which are displaced because the shoulder biomechanics gets altered because of the deltoid dysfunction. Second is a displaced large glenoid fracture, which is usually a posterior glenoid fracture. Anterior glenoid fractures are fine. And the third one is the floating shoulders, which needs to be fixed. The most catastrophic or disastrous problem with respect to scapular fractures is scapulothoracic dissociation that you forgot to mention. This is a very, very dangerous condition. When you suspect a patient with scapulothoracic dissociation, it's not necessary that you need to find any fracture. It is just the presence of hematoma along the posterior thorax and hemodynamic imbalance should raise the suspicion of scapulothoracic dissociation. Because here, apart from the scapula being separated from the thorax, it is primarily the axillary artery which is injured, and that would lead to rapid death if not identified early and appropriately managed. I have seen personally one patient who died in front of my eyes with scapulothoracic dissociation during my postgraduate days. You can do nothing. You can see him dying in front of your eyes. So identifying these patients early and appropriate management, hemodynamic management is crucial. And this is most commonly seen in case of road traffic accidents, especially bike riders who have been hit on the side by heavy vehicles which are coming behind. So that's how they sustain this injury. So we have to be very careful about that. Usually, we haven't seen in our setup because we hardly get those kind of patients here, but we should be prepared for that. This can be expected in your place in Kunur because we see a lot of bike riders who are driving rash, and there is a chances for seeing these kind of cases. Now, the next most important thing is the scapular fractures based on the locations. Now, the lateral scapular fractures, that is the lateral pillar, or the one which extends into the glenoid, is the one which needs a proper fixation because that totally disturbs the balance of the shoulder. And unfortunately, we don't have patient-specific or the fracture-specific plates in India. The most important plates like the medial column plate, the lateral column plates, the spine plates, which are needed for scapular fractures, are not available. I hope they will start making it pretty soon in Gujarat. But the ones which are best suited are from a company called Acumed. But this company belongs to Oregon in USA. So we may not be getting these plates as expected in the right time. So you have to make use of the recon plates which are there, which can be malleable. You can bend that, and no, according to the fracture configuration, we may have to change its shape. As far as the approach is concerned, yes, Judet approach is quite extensive, but you'll have a whole face view of the scapula. You can see the entire scapula and you can fix it appropriately. The other Brodsky approach has got some problem because in bulky patients who have got a huge, massive deltoid, it will be quite difficult to retract the deltoid because it's a huge muscle. It's very bulky, much bulkier than the cuff muscles. And retracting the deltoid is a challenge. And there you may have trouble. And once you make this incision and making Converting it into judo incision is even problematic because you have a wild scar in the posterior aspect, and you may be compromising the vascularity. And so you have to be very careful when you're dealing with scapular fractures in bulky patients. I would personally think about Judet because it doesn't cross any of the neurovascular structures. Meticulous elevation of the scapular muscles from the scapula, and then just protecting the suprascapular nerve near the spinoglenar notch is good enough for us to expose as much as possible. So be aware of the conditions like scapulothoracic dissociation and the floating shoulders, which needs specific attention and definitely end up in surgery. Thank you.
Yes, sir. Thank you, sir.
Regarding scapular fractures, the other point is it's really painful condition. After injury, when we treat them conservatively, that itself is a challenge. They keep coming back with severe pain at 1 week or 10 days because of the swelling and pain. So addressing the pain is also a difficult thing. They cannot lie down. When they lie down on one side, it becomes painful. The other side again painful. Arm sling, shoulder immobilizers are better than arm sling. But if the fracture is low down, immobilizer itself will be painful. So that's a little tricky situation. That taping, what we found was very helpful.
Taping is better, sir. Yeah.
Yes.
Taping is the way where all fellows must be aware of taping, even in trauma situations, where taping will reduce the pain. Even for hip fractures, taping will reduce the pain.
Yes.
Thank you.
Sure, sir. Thank you, sir.
Any blocks can be given, anesthetist?
Intercostal blocks can be given, sir, but it's more for rib, for temporary relief, that lasts only for a few hours.
Usually in the supraclavicular blocks or the plexus blocks, sir, there is sparing in the posterior aspect. That's why we give local during the procedure. So I don't think the sternoclavicular, the supraclavicular blocks will help in blocking the scapular pain. We'll have to discuss with the anesthetist.
Yeah, and the fellows can get in touch with the anesthetist because sometimes the rib fracture also could be very painful. And with the anesthetist's help, we can give a block and patient will be very happy.
Okay, sir. Okay. Praveen, you can start your presentation, please.
Am I audible, sir?
Yes, you are.
Yeah, yes, sir. Good morning, one and all. My topic is on clavicle fractures. First, we'll go to initial anatomy. The clavicle is the first bone to ossify in the human body. It is a S-shaped bone which is convex medially and concave laterally. It acts as a functional stud which braces the axial skeleton to the appendicular skeleton. The medial one third of the clavicle fracture protects brachial plexus, subclavian vessels, and superior part of the lung. The distal end of the clavicle has CC ligaments and acromioclavicular ligament. Acromioclavicular ligaments connects the acromion with the distal end of the clavicle. It is thickened superiorly. It provides anteroposterior stability. The clavicle is connected to sternum via sternoclavicular capsule, which is thickened posteriorly. It also gives anteroposterior stability. The clavicle is connected to coracoid via two ligaments with coracoclavicular ligaments, namely trapezoid and conoid. The trapezoid is attached from the base of the coracoid to the inferior clavicular ridge, and the conoid is attached from base of the coracoid to the conoid tubercle. The both clavicles are connected to each other via interclavicular ligament, which gets a purchase through the sternum and the sternal notch. Coming to clavicle fracture proper, the clavicle fracture accounts for about 2.6% of all the fractures. It is a most common fracture seen in childhood. The males are affected more common than females. It has a bimodal distribution. 80% of the clavicle fractures occurs in in the middle 1/3, which is followed by 15% of lateral 1/3 and 5% of the medial 1/3 clavicle. Coming to mechanism of injury, the most common mechanism is fall on the affected shoulder, which is followed by direct impact and fall on outstretched hand. It is most commonly seen in sporting activities, snowboarding falls, and motor vehicle accidents. It is rarely seen in seizures and with pathological fractures or stress fractures. When the patient fall on the affected shoulder, a medially driven force is generated. When this force exceeds the ability of the clavicle to withstand the force, the clavicle fails in 3 areas. It most commonly fails in the middle 1/3, which is followed by lateral 1/3, which can be either distal clavicle fracture or acromioclavicular dislocation, which is followed by medial 1/3, which can be either medial and clavicle fracture or sternoclavicular dislocation. This is a picture depicting the mechanism of injury. When the patient has clavicle fracture, we should look for associated fractures like ipsilateral rib fractures, scapular or glenoid fractures, proximal humerus fractures, femur or pneumothorax, brachial plexus injury, and vascular injuries. Coming to clinical evaluation, the patient will be presented with arm adducted and the forearm supported by the contralateral hand. We should look for skin tenting, which is most commonly seen with patients sitting in the upright position. We should look for neurovascular injuries, namely brachial plexus or subclavian vessel injuries. And chest examination should be done to rule out the hemo or pneumothorax. We should look for swelling, bruises, and deformity. Ptosis is the medially driven drooping and shortened shoulder. We should look for any prominence of the inferior border of scapula and shortening of clavicle, which can be assessed by comparing it with the contralateral side. In radiographic evaluation, the shoulder AP and 30-degree cephalic tilt view should be taken with the patient sitting in the upright position to assess the fracture pattern and displacement and to avoid the thoracic cage overlap. The chest AP X-ray is taken to compare the clavicle with the contralateral side and to look for any thoracic cage injuries and scapular injuries. Oblique view is taken for the minimally spaced fractures, and CT is the CT is taken for the medial and lateral clavicle fractures to look for any intra-articular fractures or dislocations. Coming to classifications, Alman has classified the clavicle into 3 groups. Group 1 is the middle of the clavicle fractures, which is most commonly seen in young and active patients. And group 2 is lateral of the clavicle fracture, which is most commonly seen in older osteoporotic patients. And group 3 is medial of the clavicle fractures. Ehrenberg has classified the clavicle into 3 types. Type 1 is medial 1/3, type 2 is middle, and type 3 is lateral of the clavicle fractures. 1A and 1B is the displaced and undisplaced fractures of each type. And A1 and B1 is extra-articular fractures, and A2 is B2 are the intra-articular fractures of each type. Niels has classified the distal and clavicle fractures into 5 types. Type 1 is extra-articular fracture occurring lateral to the CC ligament. In this type, the CC ligament is intact. The type 2 is divided into 2 types, 2A and 2B. 2A is the fracture occurring medial to the CC ligament. In this type, the CC ligament is intact, but the fracture displacement will be more. And in 2B, the fracture is occurring the distal clavicle through the CC ligament. In type 3, it is an intra-articular fracture which occurs lateral to the CC ligament. In this type, the CC ligament will be intact. The type 4 is the fracture occurring in skeletally immature patient, and type 5 is a comminuted clavicle fractures. Coming to treatment options, the non-operative treatment is planned for the minimal displaced clavicle fractures. The main goal of the treatment is comfort and pain relief. There is a debate whether a sling or figure of 8 bandage should be used, and recent studies have shown that there is no difference between the sling or figure of 8 bandage, and moreover, the figure of 8 bandage is more prone to cause lower trunk brachial plexus palsy. Hence, Hence, 4 to 6 weeks of sling immobilization will be sufficient, but there will be some shortening and deformity present. The poor prognostic factors for for the non-optimal management is floating shoulder, increased fracture displacement, comminuted fractures, and more fracture fragments. In operative management, the indications for operative management are displacement or shortening more than 2 centimeters, open fractures or impending open fractures, comminuted or segmental fractures, fractures with neurovascular compromise, fractures with ipsilateral upper limb injuries, floating shoulder, and bilateral clavicle fractures. Relative indications of polytrauma, the patient with significant seizures or neuromuscular disorders, scapular malposition or winging of scapula, multiple rib fractures, or cosmetic appearance. The surgical options for clavicle fractures are intramedullary pinning, open reduction and plate fixation, and for the lateral clavicle fractures, it can be either hook plate or locking plate with CC ligament repair. In intramedullary fixation, the nail is passed in a retrograde fashion, starting from lateral onset clavicle, which is driven through the fracture and into the medial fragment. Advantages of intramedullary pinning or cosmetic skin incision: less soft tissue stripping, decreased hardware prominence, easy implant exit, and lower incidence rates of refracture. In disadvantages, the intramedullary pinning will fail to maintain axial length and rotation. Operative fixation with the plate and screws. The plate is placed either superiorly or anteroinferiorly. The plate and screws will be prominent if the plate is placed in the superior aspect of the clavicle. Advantages are increased union rate and low infection rate. The disadvantage is plate prominence. Following the operative management, the upper limb should be immobilized in sling immobilization with the pendulum exercise for first 2 weeks. After 2 weeks, active range of movements can be started. In the 6 weeks follow-up, if the X-ray shows union, resistor and strengthening exercises can be started. In 3 months post-op, the patient will return to their sporting activity. This is a study done by Christopher et al. On evaluation of treatment options for medial, middle, and lateral onset clavicle fractures, which is a systemic review. In their study, they have concluded that for middle onset clavicle fractures, operative treatment is better in terms of function, union, and quick recovery. In lateral onset clavicle fractures, associated CC ligament repair with locking plate is better than other treatment options for lateral onset clavicle fractures like hook plate, tension band, or K-wires. For the medial onset clavicle fractures, plating is better option than the non-operative management, but the implant prominence is the most common complaint. This is a study done by Herman Frima et al. On clavicle fractures in adults. In their study, they have postulated a treatment algorithm plan for medial, middle, and lateral onset clavicle fractures. They studied, they have concluded that if the patient has a medial onset clavicle fractures with displacement more than 1 shaft width, open fractures, displaced interarticular fractures, symptomatic malunions or non-unions with neurovascular injury, then operative management is planned. And if the fragment is large enough, then inverted locking plate is used. And if the fragment is small, the distal humerus radial plate is used. If the patient has no indications, then conservative management is planned. In middle onset clavicle fractures, if the patient has displacement of more than 1 shaft width, open fractures, neurovascular compromise, floating shoulder, polytrauma, or pathological fractures, then operative treatment is planned. And if the fracture is simple, the intramedullary fixation is planned. And if the fracture is comminuted, ORIF with the locking plate fixation is done. If the patient doesn't have these indications, then conservative management is planned. In distal clavicle fractures, if the patient has displaced unstable fracture patterns like knee 2 and 5 with open fractures and neurovascular injury, then operative management is opted. And if the fragment is large enough, then pre-contoured locking plate is used. If the fragment is small, then hook plate is used. Without these indications, conservative treatment is planned. This is a study done by Karthik Karpe et al. On outcomes following management of unstable lateral clavicle fractures with locking plate and coracoid ankle augmentation. In the lateral in the lateral and third clavicle fractures, the treatment options are hook plate, locking plates, CC screws, KVS or tension band wiring, intermediate fixation or flexible coracoclavicular fixation. The hook plate is which is most commonly used previously for distal and clavicle fractures, has numerous complications like dislocation of hook, fractures medial to the plate, non-unions, AC joint arthrosis, cuff, rotator cuff tear, acromion fractures or acromion osteolysis. In the study, they have concluded that if the patient has a lateral one-third clavicle fracture without CC ligament injury, then locking plate shows a better outcome compared to other surgical modalities. And with the patient has concomitant CC ligament injury, the locking plate with CC ligament repair, which can of different methods, shows a good outcome compared to other methods of fixation. In their study, they have fixed the CC ligament with anchor through the plate. Coming to complications, infection is the most common complication in most of the fractures, but infection it is as came down because of peri-antibiotics protocol, adequate soft tissue management during surgeries, and adequate soft tissue closure. And neurovascular compromise is uncommon. Malunions and non-unions are seen in non-operatively managed clavicle fractures, and the non-unions are most commonly seen if the displacement is more, and the fractures with soft tissue interposition, refractures, or inadequate period of immobilization, and post-traumatic arthritis. Take-home messages: if the patient has undisplaced clavicle fractures, then it can be treated non-operatively. The surgical fixation is planned based on patient demand, displacement, comminution, neurovascular compromise, and open fractures. If the patient has lateral clavicle fracture with the CC ligament injury, then CC ligament repair has to be done. Thank you, sir.
Thank you, Praveen. We have to divide or treat the clavicle fractures based on the location. Let's start with the simple concept: the middle third shaft fracture, undisplaced and displaced fractures. We always know that the undisplaced fractures we have to treat conservatively with braces and wait for 6 weeks, 4 to 6 weeks, and then wait for the consolidation. But during our practice, we come across patients who have a displaced clavicle fracture, where it is 50-50 chance. No, you may think it may unite or it may not unite. But and also we have patients who come asking for a second opinion because they would have been advised surgery elsewhere, and they would have come to our setup asking for a second opinion. So let's be very professional and discuss these facts with a medical legal aspect, because based on the literature, any displaced clavicle fracture should be given a chance to unite, and we may have to wait for a period of at least 4 weeks to decide whether it needs fixation or not. One personal experience which I had was we had seen a patient with a mildly displaced mid-shaft clavicle fracture, and they came for the second week of follow-up, where we had readjusted the clavicle brace and the immobilizer, and we should have taken this X-ray at second week follow-up and decided whether it needs the continuing conservative treatment or surgical fixation. But at the end of 4 weeks, when we saw that the fracture was displaced and ununited, we advised the patient for surgery, and the patient were absolutely disappointed. The first question that they asked was, when we came for the second week follow-up, why didn't you take an X-ray? And it was not done. So this happened 5 years ago, and no, that was a mistake from our part. So when you treat any clavicle fracture patients, make sure that you insist on sequential X-rays at regular intervals. That is at the time of injury, 2 weeks post-injury, and 4 weeks post-injury, checking on the alignment as well as the chances of consolidation. And keep the patient aware of the fact that this fracture has a potential to heal, and it may not heal also. And if in case there is no evidence of union, then we may have to go and fix it up. And we have to say that at the first go. Initially, when you see the patients, you have to say that, because that will prepare them psychologically. If that is not done, then later on when you say that patient needs surgery, they'll be quite disappointed, asking that why didn't you inform this before? So be very professional, and whatever advice you give as far as clavicle fracture is concerned, it should be literature based evidence. The medial side clavicle fractures involving the medial 1/3 are usually treated conservatively, but if it is displaced because of the high energy trauma. Tell me, sir. Sir, you were saying something.
I thought you finished. Medial end, nothing was discussed.
Yeah, medial end can be treated conservatively, but the problem is some fractures, high energy fractures, whether it's a fracture or a sternoclavicular joint dislocation, when displaced posteriorly, that is a trouble, because the patient complains of dysphagia because of the enormous consolidation which may happen, or because of the dislocated sternoclavicular joint, or the recurrent laryngeal nerve compression, which may lead to hoarseness of voice. So these are the two complaints that the patient come with. And if it is symptomatic and if it is significantly displaced in a CT scan, then a fixation becomes mandatory. Fixation in such cases, in case of fracture, will be in the form of mini fragment screws. And in case of dislocation, pure dislocation, then we may have to do a sternoclavicular joint reconstruction with the gracilis graft. But that needs the help of a cardiothoracic surgeon. We cannot do a sternoclavicular joint reconstruction without the presence of a vascular surgeon. So you have to be prepared for that. The lateral end fractures are mainly the the ones confined to the coronoid, the coracoclavicular ligament attachments. And there are two concepts. One, use an acromic clavicular AC joint hook plate, or use a normal clavicle plate and reconstructing the CC ligament. Both can be done, but provided we inform the patient that the hook plates need a removal 6 months after surgery, because they are the source of persistent shoulder pain and even osteolysis around the acromion. So that has to be kept in mind. Fractures which are so displaced and comminuted in the lateral end, where you cannot assess the integrity of the AC ligament also, then we may have to prepare ourselves for a CC ligament as well as AC ligament reconstruction. So it is purely not just a fracture-based treatment. We have to give importance to the ligaments also. If at all clavicle fracture is malunited, either lateral end malunion or the midshaft malunion, or even the medial end malunion, always be prepared for scapular dyskinesis. That may directly affect the shoulder joint. And if you come across any malunited clavicular fractures, always tend to assess the scapulothoracic rhythm. And if it is found altered, we have to address it immediately. So as far as clavicle is concerned, always we are subjected for a second opinion from the patients, and we have to advise based on the literature evidence and be wise in treating the patients and keep them informed about your treatment strategy. Thank you.
Thank you, sir.
For fellows, Praveen, what is the X-ray you would take for a medial end clavicle? Any special views? Any other fellows? If you're suspecting a medial end clavicle, sternoclavicular dislocation of fracture, what is the view?
Serendipity, sir.
Yeah, good. But you know how it's taken?
Sir, patient is mentally supine, and the X-ray view is directed caudocranially around 45 degrees.
Yeah, good, correct. So we must be aware of this X-ray. So otherwise, then the regular AP or chest X-ray will not pick up a sternoclavicular dislocation. So you have to ask for the right views when you're suspecting this. Thank you.
Good morning, sir. Is my screen visible?
Yeah, 1 minute. Praveen, you have to unshare your screen.
Yes, sir.
We can see your screen right now, Ravi. Yeah, thank you.
Thanks. Good morning, sir. Today, I'm talking about degenerative lumbar scoliosis. The word scoliosis means crooked. It's defined as lateral deviation of normal vertical spine with Cobb's angle of more than 10 degrees in coronal plane. It is a three-dimensional deformity of spine associated with structural alteration of vertebrae. Degenerative lumbar scoliosis refers to a de novo deformity of the spine occurring after the age of fourth or fifth decade of life in the patient with no prior history of scoliosis in the growing age. Mainly, patients present with complaints of pain and disability to do the day-to-day activities rather than the deformity. Come to the pathogenesis. The initiating factor of degenerative lumbar scoliosis is disc degeneration at any lumbar level from L1, L2 to L5 to S1 level. That is, decrease in the unilateral disc space of more than 20% or a large osteophyte of more than 5 mm on one side leads to asymmetrical loading or degeneration progression leading to deformity. This leads to a vicious cycle. This leads to a vicious cycle of asymmetrical loading of the spine, asymmetrical degeneration, which further leads to its asymmetrical deformity, and it goes on. It can lead to concomitant change in disc and facet joint and progressive destruction of facet, disc, and ligaments, resulting in the joint arthrosis, laminar hypertrophy, and marginal osteophytes. In this image, due to weakness of paraspinal muscles on one side or osteoporosis or uneven biomechanical loading can leads to asymmetrical degeneration and leads to degenerative lumbar scoliosis. In a study by James Pritchard and David Bottle, it is stated that the risk factor for curve progression depends upon the parameters like Cobb's angle, vertebral rotation, intercostal line, and lateral translation. That is, as we know, Cobb's angle is the line drawn along the end plates. That is the end vertebrae. That is superior end plate of an upper vertebrae and inferior end plate of lower vertebrae, and the angle formed at the intersection is known as Cobb's angle. When it is more than 30 degrees, is considered as risk factor for progression. And rotation of vertebrae is calculated by Nash-Moe classification. What the Nash-Moe classification, what they did is they divided the vertebral body into 6 segments, and depends upon the location of the pedicle in which segment they degraded into 0 to 4. When the pedicle is located in the first segment, it is called grade 0, and when the pedicle goes from first segment to second segment, it is grade 1. When in the second to third segment, it is grade 2. When the pedicle in the midline, it's considered as grade 3. When the pedicle crosses the midline, it's considered as grade 4. When the grade 3 and above is considered as a risk factor for progression. And intercostal line is the line drawn from the iliac crest. It usually passes on the L4 vertebrae. When the intercostal line passes through the L5 vertebrae, is considered as a risk factor for progression. And lateral translation, also known as lateral listhesis, in which the one vertebrae slides over the other vertebrae. And when there is more than 6 mm of translation, lateral translation in coronal plane, is considered as significant for progression. In 2001, Edward Simons came up with a radiology classification of degenerative scoliosis. He classified into type 1 and type 2. Type 1 is degenerative lumbar scoliosis with no or minimal rotational deformity. And type 2 is degenerative scoliosis superimposed on pre-existing scoliosis with greater rotational deformity and greater loss of lordosis. This is purely a radiological classification. In 2005, Schwab and Spinal Deformity Society group classified based on the principles of basic curve location and the basic pattern and sagittal plane deformity category, and they considered the health-related quality of life. And this is further reclassified into by Scoliosis Research Society and renamed as SRS Schwab's classification. It is very simple and widely accepted classification till now. In this SRS Schwab's classification, the main parameters considered were lumbar pelvic mismatch, that is PI minus LL. Let me tell something about pelvic incidence. PI means pelvic incidence. The angle between the line perpendicular to the sacral end plate and the midpoint of the femoral head of the femur, the angle formed in suspended in this is considered as pelvic incidence, and the angle formed between the L1 vertebrae and the sacral end plate is considered as lumbar lordosis angle, and any mismatch between this is considered. And pelvic tilt, the angle between the two lines, that is the line from the center of the S1 end plate to the center of the femoral head, and a vertical line drawn intersecting the center of the femoral head. This is the line bisecting, going through the center of the femoral head, and from the center of S1 end plate, that this angle is called as pelvic tilt. And the sagittal vertical axis. Sagittal vertical axis is a global sagittal alignment. It is the length measured in mm. That is when a plumb line drawn from the C7 in a sagittal view and the posterior superior end plate of S1. The distance between this is known as SVE, that is sagittal vertical angle. It gives about the global sagittal alignment balance of the patient. And they came up with a classification. Mainly, they consider two entities, that is coronal entity and sagittal entity. In coronal entity, based on the curve location, even the degeneration can happen in thoracic level or lumbar level. Based on the curve location, it's classified into T, L, D, and N. That is, T means thoracic only. That is when lumbar curve is less than 30 degree, and when the thoracic curve is less than 30 degree, it is considered as thoracolumbar or lumbar. When both the curves are more than 30 degree, is considered as double curve. If all the curves are less than 30 degree, is considered as no major curve, that is N. And sagittal modifier is like, as I said before, it is the mismatch between lumbar and pelvic values, that is a PI minus LL. If it ideally should be less than 10 degree. If there is any mismatch between 10 to 20 degree, it's considered as 1 plus, and more than 20 degree mismatch is there, considered as plus 2. And global alignment, that is a sagittal offset, if that should lie less than 4 centimeter. If more than 4 and less than 9.5 is considered as 1 plus. If the mismatch is more than 9.5 centimeter is considered as 2 plus. And the pelvic tilt should be less than 20 degree. If it is 20 to 30 degrees, considered as 1 plus, and more than 30 degrees considered as 2 plus. Let me give an example. In this image, the patient have two double curve. It was measured, and both the curves are more than 30 degree. So it is curve type is type D. And when the plumb line from C7 goes less than 4 centimeter, so it is modifier as global alignment modifier is grade 0. And the pelvic incidence and mismatch was measured. It was less than so it was considered as grade 0, and pelvic tilt modifier was 1 plus. There was so one more example. In this patient, we can see the coronal offset of more than 4 centimeter, and there was no major curves. All the curves were measured less than 30 degree. So patient curve type is type N. There is no curve angle, no coronal curve angle more than 30 degrees. That's why it's considered as type N. And global alignment modifier, it's 2 plus because it's going more than 9.5 centimeter. And the mismatch was 2 plus. And clinical features. Most common complaint in patients were pain and disability to do daily activities. And back pain on exertion, does not relieve on sitting, often compels the patient to lie down. And the pain arises from the facet arthrosis and disc collapse and leads to stooping posture of the patient. In attempt to correct the posture, patient tends to hyperextend the back to stand erect. That further causes pain. The deformity is prominent in lumbar region. Lumbar and thoracolumbar curves are more symptomatic than the pure thoracic curve. And the coronal offset of more than 4 centimeters may be associated with deterioration in pain and function. The patient tends to be in stoop posture. In order to correct that, patient tends to flex the knee and hip in order to correct the posture. It causes the contracture and causes the retroversion of the pelvis. And it causes muscle fatigue due to the loss of sagittal balance, adds to the further deformity. And patient usually presents with neurogenic claudication and radiculopathy as the disorder progresses. On the concave side of the curve, usually there will be compression at the level of foramen or extraforaminal stenosis. On the convex side, there will be lateral recess stenosis or the stretching of the nerve roots. And on examination, there won't be any. There won't be much of motor or sensory deficit, but usually they present with bilateral ankle jerk absent. In order to understand, it is highly recommended to consider the self-evaluated measure to understand which matters the most to the patient. That is, in our hospital, we consider Osworth Disability Index, that is ODI. It includes the intensity of the pain, the personal care, and the activities like lifting, walking, sitting, standing, sleeping, and sex life, and social life, and traveling. Based on this helps to understand what is the level of disability to the patient, and it also helps post-op progression. Coming to the investigation, X-ray to be taken in full-length standing anterior posterior view and a lateral freestanding view. Freestanding view means patient standing with the hip and knee in comfortable position and shoulder and elbow flexed and fingertips touching the clavicle. What are the parameters we have to see on coronal view? We have to see for the coronal offset. Coronal offset is when a plumb line drawn from C7 vertebrae and the distance between the central sacral vertical line, the distance should be noted, and L4 obliquity angle, that is the angle formed between the superior end plate of L4 and the perpendicular line drawn to the central sacral vertical line. In a study by Schwab's in 2002, he states that L4 obliquity angle and L3 obliquity angle corresponds to the patient's visual analog score pain more than the Kopp's angle. And sagittal plane, what are the parameters we have to observe were sagittal vertical angle, that is the distance between the superior end plate and the C7 plumb line, the distance, and lumbar lordosis and pelvic incidence and lumbar lordosis should be noted in the sagittal plane. In pelvic parameter like pelvic tilt and sacral slope should be considered. The same thing in sagittal AP view, we have to see the coronal balance, the coronal Kopp's angle, L3 and L4 obliquity, and we should not forget to measure the lateral listhesis and the rotation of the vertebrae. In sagittal view, SBA deviation, pelvic tilt and sacral slope, and Kopp's angle and spondylolisthesis should be carefully seen. Next investigation is MRI. MRI is to know the level of stenosis, whether it is what level and where it is situated. That is like central or lateral stenosis or foraminal stenosis, which helps in the during surgery, where to decompress. And to know if with compression is by hypertrophied ligament flavum or any synovial cyst formed due to degeneration or any metabolic disease like osteoporotic compression fracture and metastasis. And CT scan to determine the disc level pseudoarthros, that is vacuum signing the disc space. And 3D reconstruction CT helps in the planning of osteotomies and screw placement. And it also gives a knowledge about the osteophytes situated in the disc level or at the facet level. It is important to release at the time of surgery to correct the deformity. And before surgery, we have to look for a electrophysiological study of the lower limbs to look for any peripheral neuropathies and myopathies, and which helps surgical outcomes can be compromised if there is any involvement of peripheral neuropathy and the myopathies. Before taking for treatment, the risk factors should be considered like diabetes, hypertension, ischemic heart disease should be properly evaluated. Recently, we have operated a case of degenerative lumbar scoliosis. In this patient had a corpse angle of 36 degree at lumbar and coronal offset of 5 centimeter and sagittal imbalance of 15 centimeter and pelvic incidence 52 degree, and their mismatch of pelvic and lumbar of 21 degree. And we operated and corrected the deformity. The treatment part, how we corrected and what are the parameters we look for and what approach we did will be dealt in the next class. Thank you.
Shyam, you're there?
Sir, available, sir.
Yeah. Shyam, there are a lot more.
Sir, we are not able to hear you.
Hello?
Yes, sir, we can hear you now.
Yeah. Shyam, it's a large topic. So we thought of covering the first half, this one, and the next half, Ravi can cover it in the treatment part, and the further thing can be done in the next. There's a medical management also, so which takes a longer. It's not only the surgical part. For now, this is for the rest of the thing. Hello, hello.
Yes, sir. Yes, sir. We are able to hear you.
Any doubts or anything you can clarify.
Any doubts from the fellows side?
It was a good presentation, and we do see degenerative spondylitis. Not all of them have scoliosis. And what is the absolute indication for surgery when a patient presents with degenerative spondylosis?
So absolute indications, when there is a, as with based on the classification, there is a huge mismatch between the pelvic incidence and lumbar lordosis, and the corpse angle of more than 30 degree, and lateral hysteresis of more than 6 mm, and patients health related quality, the ODI index, on considering all these parameters, we have to come to an treatment option, sir.
Okay. And I think a lot of patients keep going in spite of all that. And how do they manage? if you go to a spinal unit in Western countries, and it's full of this kind of cases. Is it because our patients do not comply with surgery, or they just put up with the pain, or is it going to be like our knee? And earlier they were putting up with pain, and nowadays they are more willing for surgery. Sriram, any ideas?
Yes, sir. Possibly, like what you said, that's true. The earlier, like I have also not seen these patients coming up for surgery, sir. Nowadays, we have a lot of we have a huge series, sir. Actually, we initially it was very difficult to convince them for such large fixations. Money was also a problem. I don't know. And now most of them have got insurance and these things. Rather than the fear of surgery and all these things only remains. Sir. They have a lot of pain. They only come because of pain, and only when they become disabled they come to us. When we suggest surgery, because it's not a small solution. Like most of them, we have to go from D11 to S1, which is a long fixation. I don't know, sir. Maybe now we are using neural monitoring for all these cases, sir, which also helps us to convince them a little bit more, because the neural part is taken care of. But basically, there is no specific indication as such. This patient should be operated, this patient is not, because there is a huge role of this ODI scoring and all. Now, it depends on how the patient looks at it. For us, anything more than 30 degrees or lateral translation is always an indication with the loss of sagittal balance. We always tell them, but then now they are coming up. Maybe it's like knee only. Now they have started realizing and they are coming up with the.
Just like a knee.
Maybe
replacement,
Yeah.
Nowadays they come move forward. There's one question. It's thing like Tai Chi, which is done for done in the Eastern countries, which actually keep the spine also, especially spine, subtle and straight. Is the incidence of degenerative spondylosis and surgery less by any chance? Any idea?
No, sir. No idea. Maybe. But at least one thing that we have noticed, we can tell that those who are doing yoga and all regularly don't come with this kind of a problem. Only and more common in females, possibly because of the osteoporosis. And those who are a little less active are the people who get into trouble. There should be a role, sir, definitely, but no proven.
You can go do a very good prospective study on the IMA members, because yoga is taken very seriously over there. You can follow them up over a period of 10 years or something like that, and see how much the yoga is really helpful. And you have very good control subjects, I'm sure.
Yes, sir, they may be. Yes, I will consider doing that, sir. Okay.
Thank you.
Thank you, sir.
Thanks, sir.
So can we end meeting, sir?
Yeah, please. Yeah. Thank you.
Thank you, sir. Thank you.